Everybody has a mic, yes? Very good.
Yes, yes.
Okay, so this is the panel thing. You can shout questions at us. This is MIT. We can interrupt each other. Please tell me questions from the audience as they come in. And so in order, I will address you in the order that you spoke for with the first question, and then you can actually throw questions to each other as well. I'm going to give a very direct question to Ilya. I'm sorry if it's too much. But given the fact that you can raise these cells now, and you can raise them quite well, what is stopping us from having some of Tara's stem cells given to you so you can transfect them and express olfactory receptors, and then we'll transplant them back into her head?
Nothing. So I think what matters is what the actual problem is, and that's actually one of the things I wanted to ask you, if it's not too personal, but what is the pathology kind of like, and do they know kind of at what step in the process the sense of smell is gone? But yeah, so from our perspective, we can take specific even like genetic variations of receptors, put them into cells, express them in our cells, and then look at the kind of differences in the signaling. So, for example, like we know that there are, that people perceive things differently, right? So like the classic example is like cilantro, right? So some people think it tastes great, some people think it tastes like soap. So that is a genetic modification in, I believe it's a taste receptor if I'm not mistaken, but it's the same idea in olfactory receptors, right? Where a single nucleotide mutation can totally change the function of the receptor, and that, of course, affects your perception. So short answer is yes, we would absolutely love to do that. There's, as far as I know, nothing stopping us.
Well, other than perhaps an animal study first, before you start digging into her head. Okay.
Yeah.
It depends on how invasive the procedure is. You can gladly, take it from me. That's what I'm here for. And so I just want to answer your question real fast about like where I am in the process. So I learned that I was anosmic probably when I was about 9 or 10 years old. And I went to some doctors. They put the metal snake, as I used to call it, up my nose like 5-6 times. Everything's fine. Then I get sent to a specialist and, as I like to say, gets my head examined. They took an MRI and they found that I have like a 13 millimeter cyst in my pineal gland. And after that, it's like nobody has really been able to help me. I don't know what I can do, where to go from here.
So that's fascinating, and I want to ask a follow-up. When they found the cyst, did they also tell you anything about your olfactory epithelium? Was it it's there? I'm sure they would have said, "Oh, you don't have an epithelium or a bulb, olfactory bulb." I say this, and I'm addressing now both Laura and Stella as more specialists in this. You might know about this. There was a paper published a few years ago by Telly Weiss, who was in Noam Sobel's lab in the Weizmann Institute in Rehovot in Israel. A fantastic olfaction lab, by the way. And what they found was, by scanning a bunch of CAT scans and MRI scans, that there were women, for some reason only women, and for some reason mostly left-handed women, that had zero olfactory bulb present. The tissue was gone, none, zero. And they had absolutely no difference in their olfactory abilities than people with an olfactory bulb. These women had no olfactory bulb at all, and if you didn't scan them, you wouldn't know that they don't have that because they did not present as anosmic, and in fact, in the paper they say, well, there's some way that perhaps the neurons go straight into, the olfactory sensory neurons go straight into the head, and that will give you some basic understanding. But these women said, no, we can smell just fine like everybody else. They were accurate, they were precise, and they had zero olfactory bulb visible in the scans. So something very interesting is going on, and I would like the two doctors here to talk us through what, maybe we can even ideate right here with Tara in the room. What else can we do? What tests can we run on her to first of all find out what is causing her anosmia? And afterwards, Tara, tell us about your two experiences with actually smelling things, perhaps. Go ahead. No,
Oh.
the two
Yes.
doctors, please. And, I should give you the
Should I
order.
start?
I think maybe
I don't
Dr.
think this
Stella
works.
Lee first, because she spoke first,
Oh,
and then
yeah,
Dr.
okay, I'll start.
Laura.
So smell is quite complex, and I think even with auditory perception, we look at, sensory neural or conductive loss or mixed loss. Sometimes as I showed you on the video, you can have obstructive polyps, and that can give you like a conductive loss where you're not actually getting any odorant into the actual receptor area, no nerve stimulation. You can have sensory neural loss where the nerve itself is damaged. And then I think there is this, then we talk about peripheral and central neuronal loss too. So the problem can exist at many levels, one or mixed. And so that's where I would start. And I think it sounds like you've had a lot of the imaging done just to check if the olfactory bulb is there, and we commonly see patients who have tumors of the olfactory nerve and the olfactory bulb, and we actually have to remove the olfactory bulb for a tumor called esthesioneuroblastoma. But it's interesting, your comment about the patients who didn't have an olfactory bulb. There is a disease called Kallmann syndrome. I don't know if you've heard of that. It starts with a K. But these patients are born without olfactory bulbs, and I don't think that they can smell. So I'd be curious if there is a, and this is where we need more research is, there is a map, in the olfactory cleft in humans. We've defined it a bit better in animals, but not so much in humans. And then the map that's corresponding in the olfactory bulb, and then the map that's corresponding in the brain, which is also very complex. So, yes, that's where I would be thinking. The different types of conductive or sensory neural, peripheral, central, and where perhaps the obstruction is happening or the dysfunction is happening.
So I was going to say, please come and join our study. So Dante here actually and Caitlin have developed a super cool way of digesting taking cells from a swab. So Dr. Lee can swab your nose at the olfactory cleft. And we have been submitting samples for single cell sequencing so we can figure out what's happening in each cell that comes from this area, and we can understand whether your olfactory receptors are expressed at normal levels. We can understand whether the olfactory receptors signaling downstream and signaling molecules are there at normal levels. Do you actually have olfactory neurons? Maybe you're just not developing the olfactory neurons. And I think we have been trying to develop this better, get more biopsies from our COVID anosmia patients, or even patients who have normal loss of smell from chronic rhinosinusitis. And our ENT colleagues frequently say, oh, we cannot biopsy the olfactory cleft or the olfactory organs because we worry that it's such a small area in humans that we're going to damage this particular patient's ability to smell. But if you can't smell, maybe it's okay to biopsy. And then we can do some of these fancier new techniques that have been very well validated for all kinds of diseases, but because in humans the olfactory cleft is so small, we haven't been able to access it in a larger scale of patients.
I wonder, during a deviated septum operation that I had, they packed me with gauze, and then when they took it out, of course I went anosmic for 2 weeks because my epithelium was stripped away. After 2 weeks, the smell started coming back. Interestingly, I do not like yogurt at all, that smell of fermented milk, and that's the first smell that came back, perhaps because I find it so strong, or maybe that's why I don't like it. Maybe I have an overexpression of receptors for that, and I find it very strong and very off-putting. So that's the first smell that came back. However, it also tells me that possibly you shouldn't worry so much about biopsies. I mean, if they stripped the whole thing and it came back out of my head, or is that in a different spot? Or alternatively, you could go maybe not do it to Tara because she doesn't need one, but for people who have had the surgery, right, when you rip out the bandages, what remains there includes some stem cells, right?
Oh,
You're
goodness,
not a
it sounds
physician.
like-
The United States and the U.S. legal system will go
gosh.
after you.
Yes,
Yeah.
we are very, very careful not to touch the olfactory neuroepithelium when we do septoplasty. Septoplasty is a very common surgery, but I describe it to patients that we're lifting off like tissue paper off of cardboard with the mucosa very low. And we know we need to preserve a strip up high where the olfactory epithelium comes out, but even for the structure of your nose, otherwise your nose would collapse. So I would be shocked if they, oh gosh, it sounds terrible. We're very, as surgeons, we're very meticulous, and the technology has come such a long way. Maybe, did you have your surgery a long time ago?
Yes, it was maybe
Yeah.
12 years ago.
Oh god, well that's not that long.
No, that's
ago.
not that long. No,
Yeah,
but I'm serious that's one of the ways that people apparently can harvest their own stem cells is by after undergoing this operation, as the gauze is pulled out violently. I have to say, it was the most pain I've ever
Yeah,
experienced.
we don't use
It
gauze
ma-
anymore
It makes
either.
it makes a
Yeah,
sound
I'm
too.
not-
The sound
yeah.
of your head, of your brain literally
Oh,
being ripped
goodness.
out of your head.
So everyone in the audience, we don't do surgery like that anymore. It's much more humane.
God, I missed the train.
Yeah, which is good. We really have to consider that. But yeah, with septoplasty and also with sinus surgery, it's interesting. I think with sinus surgery, there are patients that I've met that back 20 years ago, they've had sinus surgery and they were able to smell, and then they can't anymore, and they think, gosh, maybe it was. That's why we have to think as surgeons. What is the olfactory reserve of that patient? And as we get more interesting like therapeutics that are like monoclonal antibody therapies that decrease inflammation, because you can go from a very, very basic sinus surgery where you're just opening up the sinuses, the caverns, the labyrinth, rather than what another more, the opposite extreme is like actually drilling out the entire frontal sinus cavity, so you're making one common cavity, so we use a drill to do that. It's called a draft 3 procedure, and so there's a lot of debate among our community about how aggressive do we need to be surgically in removing tissue. And when we do skull-base surgery, when we actually remove brain tumors through their nose, we're very careful to, when we create like this flap along the septum, we preserve a little strip where we know the olfactory epithelium comes down, so we don't destroy that patient's sense of smell. So, but that's an area that definitely needs more research. But thank you for sharing your experience.
I have another question for all the doctors and Tara. Tara said that she is humanely and what's the word, philanthropically sitting at the back of the plane to save the rest of us from that smell. Thank you for that, Tara. But I wonder, because I used to teach that olfactory receptors are only expressed on the epithelium, that the nose is a snout, really. It's there for humidification and hydration of and warming up the air. And that the only other tissue that expresses an olfactory receptor is in sperm, OR17.4. That ended up being a mistake. We now know that olfactory receptors are expressed throughout the body, including in the lungs, including in places where air does not go. And during development, olfactory receptors are expressed to actually guide the fusion of tissues. So when your flesh finds its partner to fuse, it's because there's temporarily expression of olfactory receptors, and their cognate ligands, their odorants, are being left behind like breadcrumbs so tissues can find each other. Then those stop being expressed. So my question is, even if we don't have perception of olfactory signals, can we measure that the body perhaps, not conscious perception, but can we measure that the body perhaps does react? I think that if you're sitting around in a stinky atmosphere, you might get stressed out, right? Because your immune system will say, oh, get out of here. Is there experiments we can do on Tara, who will objectively tell us, no, I can't smell the poop, I can't smell the porta potty, but perhaps her galvanic skin response or another measure of stress will be elevated. So maybe your philanthropy is at a cost. Maybe it's not free for you. Maybe you're getting a little bit more stressed out, a bit more fatigued, because we know it's not just your nose, even if you're not consciously perceiving it. Now, there's another researcher called Debbie Donnelly from Harvard. She's also a pilot for UPS Airlines, a captain. And she did some research finding out that the freshly brewed coffee, when presented to pilots, professional pilots in a simulator, when they have to habituate to that smell, which is often present in the takeoff and landing phases, they actually decreases their cognitive capacity by, I think, something like 10%. They make more errors during the most critical phases of flight because their brain is busy actively suppressing the signal. That's what happens during habituation. You actively suppress the signal. So when they're brewing coffee before takeoff and landing, they're actually making the pilots dumber. That is a bad idea. So either we filter the air to the pilots or we don't do this during takeoff and landing. You can do it when they're cruising. But this was a striking finding, actually, by Harvard. So that's why and even I bet you that being bathed in a bunch of odorants does something to your body, even if you're not perceiving it. What kind of experiments can we do on Tara or other anosmics that can find this out?
Functional MRI? I mean, I think a lot of the neurocognitive research uses functional MRI. We don't. But I think ENT probably has started doing that. Yeah, I mean, functional MRI is a very well developed neurocognitive test now. So we can spray all kinds of obnoxious smells around you. And as long as you're not claustrophobic, you can sit in an MRI and have different parts of your brain examined. Yeah.
Well, that's what I'm here for, guys. I know you're all like,
Success.
I'm the guinea pig in the room. No, that's why I've put myself here in this situation because, hey,
No, I love it. I think that the Tara is an important data point about to start generating more data points because I've been in this business for about 18 years now. Anosmics come and go, but to have a proper anosmic who's actually interested in being experimented upon, yeah, we should not let that opportunity go.
Yeah, curious too, also if your total number of olfactory receptors are lower globally too, not just here. And you bring up a really important point about air quality, and I think we're more conscientious about it. That's one of the areas that I'm very passionate about. And as we have increased air pollution, we look at PM 2.5 or particles in the air that are less than 2.5 micrometers in size. But I think in the future, all of us, hopefully, our homes have thermometers, right? But why don't we have air quality monitors so we can detect, like for patients who cannot smell, to be able to tell us what the quality of what we're being exposed to on a constant basis that can impact our overall health. Because the air that we breathe is so fundamental to our health, besides sleeping and all those things. But obviously, can't live without, I guess, as a proper ENT would say, A is for airway. And, I think the components of the air is super important. So I wonder if, because you can't smell, like if there was, like for me, if I'm walking, like yesterday, for example, we were walking across the street to lunch, I knew there was construction, there's all this diesel and gasoline burning and things like that. I automatically knew to like cover and like, go away from that place and maybe go sit inside. But, I wonder, if you've had more insults to your body too, for lung or skin or other, diseases that you become more susceptible.
I have
to.
one more question for Ilya, and then Carolina will give us questions from online. Because I'm such a friend of aerobics, I think I'm allowed to push them back a little bit on some things. I love the ambition that you guys said that there's nothing really stopping us from doing this other than the ethics and humanity of it all and making sure that we don't screw things up. If we were to go a little bit less dangerous and say one of your pallets that you create in aerobics can be installed in Tara's house or in Tara's fridge, and maybe she can, with cartridges or something, because your cells don't live for very long, apply it to her, I don't know, deli meats or whatever she has, so she can be confident that something is not rotten, so she doesn't throw away as much food. And it's not just about Tara. The planet is suffering from food spoilage. If we had an easy, sort of a litmus test, quick and thing, because you can't have supermarkets tasting everything or touching everything, some way to use your technology perhaps to tell us about food spoilage, it would be a significant fix for the planet's woes.
Yeah, I'm really glad you mentioned that. That's definitely an area that we're looking into. So one of our potential customers came to us with a problem of, they are one of the biggest producers of pork in the world, and apparently I just learned this when talking to them, but the gold standard way right now that they kind of ensure that every pork carcass that's hanging in the meat locker is still safe is they literally have people going around carcass to carcass and sniffing it. And that's just because, and I had a very similar reaction, like, oh my God, I can't believe that this is actually happening. But they said, look, the human nose is just so much more, like we are able to pick up, especially with these, like the really, really bad molecules, like we can pick up parts per billion and parts per trillion, that even if they do a biopsy of the meat, they're not able to pick that up, right? They can't pick it up with GCMS. And so, so that's, and for us, it's like, that's kind of the use case because, we know that if a human can smell it, then there is some receptor, at least one receptor that's being activated by it. So yeah, this is 100% something that we're very interested in.
So do you have a panel like you have for the pleasant smells, for the unpleasant smells?
So the challenge now with olfactory receptors is that for the vast majority of them, we don't actually know what they do, right? And so we'll have, as I mentioned, we have this combinatorial code where we'll have the same receptors activate to the pleasant smells as we do to the unpleasant smells. We'll have some that are they're called specialists, that are more specialized. But yeah, so we do have, to answer your question, we do have some receptors that we think are more responsible for the malodors, but that's just because empirically we found that they react to some of the malodors. It's not the case that, like there's these 10 malodor receptors and all we need are those 10 to detect malodors. Unfortunately, this is an extremely complicated sense where, we really need to just capture everything or capture as much of the data from receptors as we can.
And I missed that, but do you have one receptor expressed per cell? Each
Yes.
cell has one unique receptor expressed. Oh, that's cool.
You opened up a can of worms there, but I want to give it to the web. Yes, that's a great question.
So we have a question from Dr. Fletcher to Dr. Stella Lee. Why is magnetoencephalopathy needed to study the olfactory brain? Do the paramagnetic particles in the brain play a role in the smell? Paramagnetic.
Oh, fascinating. Yeah, talking physics. Yes, so we wanted to understand how olfactory stimulation affects the brain because we know that there's a connection, a very intimate connection between smell and memory and cognition. And also to validate some of, we know that the neurons are there, the receptors are there, but I think it is much more complex than that. And even the concept of malodor versus pleasant can be subject to interpretation because someone like me, grown up in a Korean American family, kimchi and stinky tofu and all those things are actually pretty pleasant. But for someone who hasn't grown up in that, it might actually be very unpleasant. So the interpretation of that neural signal, I think, is important. The upper, processing of that neural signal is important, and how it colors our world and how we experience the world. That's I think very interesting to me, especially for people who can't smell, but also people who are, as I mentioned, super smellers or super tasters. Like, how can they differentiate those types of different odorants? And then now in Italy, what they're with Michel Kripa, who's the super taster, how he's really looking at the way that they're doing smell training is very different from how they do in the US because we would never have the time to do it here. But he uses iconic scents of Italy, I guess, associated with holidays or other events in Italy. And then he takes hours with the patient to then associate that memory of that iconic scent to that particular odorant, and then they do the training for hours on end per day. I said, Americans will never go for that because it's going to take way too much time. But I guess it's a long way of saying that the cognitive interpretation of the neural impulses that occur from the receptors to the brain, I think, are very important and should not be ignored because we can learn so much from that.
I think unless you have some closing remarks, we could let everybody go for lunch.